On this special episode of the ASC Podcast with John Goehle, recorded live during the Fall 2022 New York State Association meeting in Tarrytown, New York, we interview some of the speakers at the conference and the leadership of the association.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 171 of the ASC Podcast with John Goehle for October 29th, 2022. Recorded live during the Fall 2022 New York State Association of Ambulatory Surgery Centers conference in Tarrytown, New York. This is Sue Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Remember, the ASC regulatory environment is extremely dynamic, and the material provided in this episode is based on information available as of the date of the recording. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies and recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory accreditation and finance issues.
So we recorded much of this material, or all of the actual interviews, during the Fall 2022 New York State Association meeting in Tarrytown. We had a lot of fun there. We actually had a huge presence there, Ambulatory Healthcare Strategies. We had 12 of our employees there, which we can do because it's right down the thruway in our state. But we had a lot of fun, got to listen to and see a lot of our listeners, of course, of the podcast, and got to meet new people and spread the word about the podcast. But it was a great conference, highest attendance that we've had ever. And, of course, the New York State Association is growing, as you're going to hear as we talk to some of the speakers here. And so we were also very fortunate to get a lot of interviews. Not that you were part of it, unfortunately. You were busy manning the booth and manning the registration desk while we were there. But I did have an opportunity to meet a lot of great people and get some very good, solid interviews from everybody. So let's take a break, and when we come back, we'll have each of those interviews from the conference. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com.
Our first interview is with Amanda Penrod, PhD, CASC, CEO, and co-founder of RFX Solutions.
So we have gotten to know RFX Solutions in the last couple of months. They are one of the premier providers of various web-based services for the ambulatory surgery industry, and I had an opportunity to talk to Amanda about the evolution of these type systems and where we might be heading in the industry. So let's listen to the interview. So I'm here at the September 2022 New York State Association meeting in Tarrytown, and I'm here with Amanda Penrod, Dr. Amanda Penrod. I love saying that. You know, I have a lot of friends who are PhDs.
Thank you, John.
So
I appreciate
I say that not in a negative way at all.
Thank you.
You are the Chief Executive Officer of RFX, and our company has gotten to know our ambulatory healthcare strategy has gotten to know you very well over the last couple of hours here as our staff. We have 12 staff members here, and each of them, I think, is visiting your booth, not just because of your potato.
Our potatoes are a great conversation for people.
It does start.
Yes, it does.
But every one of our employees is walking around with one right now. But you have a solution for the marketplace, which is interesting, and it just generates this whole question. It's the point that as we develop further as an industry, as a professional organization, professional ambulatory surgery centers, as we get more into, quality reporting and being able to quickly provide information for surveyors or for the government, for that matter, we have to find better ways of doing that. And for the longest time, so much of what we do is on paper. For example, credentialing files. They're all paper for the most part. Some solutions are out there. Chart audit tools, survey tools, those famous checklists that we all have.
Right.
And so I thought that we would start our conversation by just talking about the where we are right now and what we're finding our customers, maybe just even a little bit of a dialogue about what our customers are looking for.
Yeah, John, I appreciate the opportunity and to talk about it. And I think the potatoes kind of lend itself to a great opener for this. And so they're stress ball.
Right.
And
or stress potato, I guess.
They're a stress potato, yes. And really, it's our clients are buried. And so when we start talking about our administrators, our DONs, and our staff there, they're not, it's the paperwork. Yeah. It's the compliance, the regulatory. It's keeping up with credentialing. It's what's happening with my vendor contracts. Where are they at? My staff records. When is that staff license expiring? When it comes to compliance and our compliance logs, did we actually complete them? But even more importantly, the next step to that is if they did and there was a compliance issue, was management alerted? What aspects of patient safety are being impacted? Yeah. And so when we talk to our clients, and we'll just go to provider credentialing as an example. What I hear so often is how buried they are and the want to make a difference in these other areas, but the inability because they don't have the capacity.
Yeah.
So our goal and our solution is for us is to really take all those binders, those file folders, all those documents, the logs that they have to compile that together in an automated, digitized format. Interacting with our staff, our vendors, interacting with our providers through this, but also grabbing very valuable data, giving oversight. So now I know where I stand in this. So now I can go focus on what other aspects are happening in quality today. What about the aspects of the OR that may need additional attention, and taking the lift and the burden from them on the paperwork. And it's significant.
I actually have a story that occurred today with one of our clients. 12 of us are here at the conference. We have 20 employees.
Yeah.
So we literally had a story today where one of our centers, we discovered about late last night, their suction machine, one of the two sides. So the way a suction machine works is that you have two pumps, and one is always working and the other one is on standby, and then they switch back and forth. Yeah. But you always have to have a backup, just like a generator. You always have to have backup power. Well, one of our staff went in yesterday and discovered that the backup suction machine was out of service.
Yeah.
And there was a disconnect between the person who does that inspection said, oh, yeah, it's been down for a while. And the people that actually manage the ordering of the services there. So as I'm listening to you, I'm saying there is a perfect example of, your dashboard being able to, highlight that, as well as, again, one of the mistakes here was somebody didn't pull out the checklist.
Correct.
to do that double check. So talk a little bit about, I mean, even a life example, a real life example.
No, I've had them myself. So prior to developing and starting RFX, I actually, 20 years experience in healthcare, running ASCs. I myself had similar experiences.
Yeah.
You know, all of a sudden I had a piece of equipment. We thought that there was preventive maintenance being done or service. It didn't. It goes down. And now not only am I having to service it, bring that piece of equipment up, the cost and the immediate cost outlay was tremendous, and it shut our ORs down because of it. And
by the way, that's what we had to do.
Yeah.
We had to tell them that they can't do any operations until they start. So again, exactly what you're just saying.
I mean, and so it's very costly. So not just in the cost outlay of what needs to happen to bring the equipment back up, and with that vendor, but I've shut my ORs down. I've got frustrated surgeons. I mean, I've got staff, patients. It's a domino effect. Yeah. And so, but at the end of the day, it isn't these administrators or DONs, material managers, whoever's responsible, not wanting to do that. It's a time and a capacity issue, and they need better tools in front of them that's alerting them, saying, you know, the next 30 and 60 days, these are all of your preventative maintenance or service contracts that you need to be servicing, and having a tool that automates that and helps track it for them and then maintains it. And because in the absence of it, it's buried.
Right.
So
I want to move on to one of the more important, and again, I know we're focusing on your tool in particular, but this is a community, this is a industry-wide issue, and that comes down to credential files.
Yes.
Our organization, Ambulatory Surgery Strategies, doesn't do credentialing, but we oversee those files. And for the vast majority of our centers, they're still on paper. Maybe they, have electronic versions of it. We've been toying with some of the online services that are out there. Some of our clients use CVOs, which, interesting, as I'm talking to your staff at your booth, they were saying the same thing I do, kind of like secretly, like we all hate CVOs. We really feel that many surgery centers find they're actually useless because they get you into more trouble. I was telling a story about, as a surveyor, when I go out and survey an organization, if you tell me you have a survey or a CVO, I immediately know what to look for because the average CVO misses that. Right. So it's almost like you tell me you have a CVO, I automatically know exactly what's going to go wrong with it. But I think there is a huge role in the future, or now, not even in the future, for computerizing this, but doing it in a relatively simple way, something that's really accessible. Talk a little bit about how you approach that. Well, talk first about the problem, and then how you solution.
Let's talk about the problem, because from an industry perspective, and this is coast to coast wide, and it's things that we are even seeing with our clients, but even in talking to people at conferences and so forth, the inability, first of all, to have visibility on what needs to happen. But second of all, the complexity of it, staying up with all the paperwork. And as you know, that credentialing, for many of them, I mean, depending on their bylaws, is either going to be a 2 or 3 year process. But in that time frame, we have multiple events that are occurring with licensure expiring, OIG checks, insurances, et cetera. And they miss these gaps and these opportunities. But it is very labor intensive, and just managing the paper is what makes it complex. A lot of the process is not actually that complex. It's just the number of events of expiration. And so giving individuals tools that can help them track that in a more meaningful way, and that keeps that current, allows credentialing to no longer be, as we've seen, a full-time job in high volume centers, to something that really could be, a fraction of that. And so then being able to repurpose, instead of just handling provider credentialing file after credentialing file. And then at the end of the day, to your point, even working with some of the CVOs, and some of them do a good job, we're also finding that the staff in the center, when they're working with the CVOs, are still having to chase down, we need an updated DEA license. We need an updated medical license from the practice. And so it's at those moments that it just continues to convolute and weigh down the actual, just the needs of the center and what they're trying to do. And they're chasing people in the process. And so it lends itself to huge gaps. And one of the things I will tell you with our clients, we have yet to onboard or even talk to any of them that are 100% compliant with credentialing. In fact, the gaps are vast. And
that's been our experience. Actually, we were talking to your staff at the booth that we as a company and the ASC Podcast has had to step in recently because of the huge knowledge gap that occurred after COVID, where a lot of credentialing coordinators had years of experience just said, I don't want to go back to work after this.
Right.
It really didn't have anything to do necessarily with the job. It's just they decided, I'm kind of done, with everything going on. And that education and training, the knowledge that they lost from those people who have been doing it for so long. And I think your tool, so here's one of my pet peeves about this. Often when you're talking to the owners of surgery centers, they look at all this paperwork as, just get it done. It's just the paperwork. As I'm listening to you, I'm thinking to myself, your products handle that background stuff so that the ultimate solution is what you call a dashboard. In other words, something rolls up and says, out of all that data that I've collected, this is your problem. And that's really the solution here, because your data, your product, and there's other competitors out there. Again, not to mention, but the idea of using software to gather this information so that you don't have 1,000 pieces of paper that you could easily lose, that often could get overlooked because you check the box and forget to follow up with somebody. There's no cross check on that check. When you checked it off, it didn't notify somebody else like your software does.
Yeah. John, as you're mentioning and talking about that, what we're finding right now when we start looking at all contracts and agreements, their staff records, provider credentialing, particularly for organizations who have been established for a while, when we go to build them, it is anywhere from 40 to 50,000 sheets of paper.
Yeah.
And when you think about the sheer just complexity in managing that, it's easy to miss stuff.
Yeah.
And some of that is very critical to how we operate and our patient safety and requirements for regulation and compliance. And so it's helping them close, that paper gap. I mean, not to mention, we talked to some of them, even on logs, as an example, they get frustrated if they have an infection and they're like, we need to do a tracing. But to go and even find, they're like, I think our boxes for, this are in a storage, I don't know where, and the hours spent having to dig versus having that data very meaningfully available to them so they can look at it and know, these are the problems that we had or we didn't have, and quickly be able to extrapolate that out. But the dashboard is hugely beneficial to them. At any given time, an administrator knows this is where I'm at in my center. And, and then likewise, if we know there's a lot of turnover, and and a lot of new administrators stepping into roles who need to learn. And it's like, how do we give them intuitive solutions? The business and these complex business problems, and put it in a more simplified manner so that, the individual who has a clinical background, and we know about 85-90% of our administrators are all clinical.
Right.
How do we help them drive these business in a more meaningful way? And that's, is important to us.
Amanda, project into the future, if you can.
Yeah.
You got a doctorate. You should be able to do this.
Yeah.
Project into the future, maybe 5 years from now. Where do you see surgery centers with regard to utilizing software? I mean, I kind of know what your answer is going to be, but it's kind of interesting to see what the marketplace is going to look like at that part.
Well, one of the things I'll say with the pandemic, we know there's been an acceleration to, individuals adopting technology. And
because of not having the staff to be able to handle that.
Not having the staff to be able to handle it. No, when I look at the next 5 years and we have, we're seeing, we already started to see the paradigm shift of everything going into the outpatient ambulatory settings off the hospital. It's going to be critical to our surgery centers. It's actually one of our purpose and our passion is behind this and giving a lift into an area, even into these organizations, in terms of what needs to be compiled from a data perspective and helping them manage it from electronic, documentation. But also, moving that, it's not just for us. One of my passions as well is I see a huge value in the EMR side. That's not us. But when I hear administrators and I ask, I'm like, what is keeping you from adopting even EMRs? It's time.
Yeah.
And the time to implement and focus, because they're like, I'm buried in all this other stuff. And so when I think about we start bringing these solutions, then more and more of what we do from a documentation standpoint will be digitized. More data will be able to drive in more meaningful ways. And the industry needs it. We're growing leaps and bounds, and we're not going to stop. Yeah. And it's something that, unlike our hospital side, where, they've got much more bandwidth and bench strength. They've been around. Data's been collected for a long time. We don't have that side of and in the ambulatory setting. And so we need to help give that lift.
And we have so much turnover, and the people that come into the ASC industry don't have the degrees in all the different areas that the hospitals are able to hire. You can hire, experts in data programming and finance and all those things. We just don't have the resources. We have to find it in one individual or a series of individuals. Very good point.
Yeah. So,
Amanda, this has been a pleasure. Thank you so much for talking to us.
Appreciate it. Thank you, John. Have a great day.
Thanks, you too.
Wow.
Our next interview is with Don Bisbee, the CEO and president of Value Health.
So I'm here at the New York State Association meeting in the fall of 2022 in Tarrytown, New York, and I'm joined by Don Bisbee. He is the CEO and president of Value Health. Welcome.
Hi, John. Thanks for having me.
I've had Dan, on our podcast a couple times here, and we always have a great conversation here. We're slightly different focus today. We're going to talk about, what's happening in New York. New York is famous for being a state that the big management companies haven't come into traditionally. And a little bit of history for myself. I've been in this business for 32 years. So one of my first center that I worked on was one of the first 20 centers. So
fascinating.
I've lived in this world for that long, and it's we've just never really thought seriously about management companies, and of course now we're starting to see them. So talk a little bit about your adventure into management companies here in New York.
Yeah, sure. Thanks, John. So, as we, as Value Health, as some may know, we started in conjunction with New Health as the management company. And our founder, Dan Tassett, had the foresight to understand that the industry was going to change. Now, certainly the move to ASCs in itself was a change, and continues to be a huge opportunity for value in the United States healthcare system. But I think the thought was, what's next? What's beyond that? And so Value Health was kind of born in this vision of those who pay for care are going to have a greater expectation for value from those who provide care. And so that's where we began. And it began by thinking about the concepts that are very familiar to all of us around consumerism. So what do we expect in our consumer world? And so why don't we have those same experiences in healthcare? And as we all know, that generally in healthcare, we, the consumer, whether we at a given moment are a patient or not, we bend around healthcare and how it decides to function. And as more of the cost has been shifted to the consumer, and they're paying more through premiums and they're all the components of that. When you pay more, any of us, we have higher expectations. And that's really what's happening in healthcare. And so it's not just the convenience of the shift of site of service, which ASCs absolutely provide, and in general, a lower cost, but it's taking that further and to say, what would change the experience and what would create a kind of draw for both the consumer to want to go there, funded or supported by who pays for the healthcare, generally our employers, and how would we make sure we end up there, and not just by the decision of our caregiver, but really by a directive by those who pay for our care. Right. And then when we get there, that we have this amazing experience, great outcomes, and a total value. So Value Health began to build what would a program look like that basically connects those who pay for care to those who provide it, and take what the employers want, which is a better experience, great value, and I want to know that my people are going to end up in these locations, and I want to direct that because I'm funding the bill as the employer. Right. And on the other side, and this is really what we'll talk more about today at the conference, because there's so many of the ASC managers here, is what is it that we do to enable them to be ready to respond to that demand, making a choice? And that has to do with a programmatic approach to higher acute, more complex cases, which we want to see in the ASC, but doing it in such a way that it's programmatic, driven by clinical protocols and evidence-based medicine, having the technology to capture all of these great things that are happening so we can report outbound back to those who pay. We got what we thought we were going to get. And so that's kind of where Value Health took that step in. And then today, we have kind of separated from the management. New Health is still managing, and Value Health is focused entirely on the value-based care segment, engaging with employers through our engagement platform, and then working with ASCs and physicians on these programs that have started in orthopedics but are now moving fast into cardiology and bariatric.
And you have a great example of a center in Pennsylvania, or a
Yeah.
couple centers that I visited and talked about during one of our podcasts. Talk a little bit about that experience, because I think it's important to see, how everything can come together.
Yeah, when you take the perspective and you start with the consumer perspective, you begin to think differently than if you start with the healthcare setting perspective. And so that's what we did. And so where that change is initiated is even before the day of your surgery, we set up a interaction, and I'll use orthopedics as an example. We set up a time connecting with that patient to come to the center ahead of time. We greet them and talk about what to expect. We talk about what will happen the day of, things they may need to do ahead of time, and let them know that part of that day of experience, aside from the actual surgical event, will be that they'll stay a day or two with us depending on their acuity level. We talk about what to expect beyond that. So we really foreshadow the entire event, not just, hey, here's the things I need you to do so that we have a successful day of surgery. Certainly that's part of it, but much more than that. When they show up day of surgery, we greet them, I would describe much like one might be greeted if you were a known visitor to a five-star hotel. We know who you are. We know why you're there. And
they know the facility. They've already been there.
That's right. And no concern morning of that
correct.
I can find this place because I've already got the jitters about what's going to happen. And when they get there, we take them right on into the intake and begin kind of just playing out what we told them would happen that morning. And so it's familiar. Familiarity creates comfort. They go through, they have a great procedure, and when they come out, we take them right into the stay suite area, which is, in most cases, directly adjacent to the facility. It's not a hospital facility, but it's licensed as a hotel. And we take care of them there for 1 to 2 days. And the great thing is that during that stay, we get them their first round of PT. Yeah. By the way, oftentimes we'll have spouses who stay the night, and that's okay. They've told us what they want to eat, so they get exactly what they want. That's comfort. And we enroll them in our technology so that when they go home, we're able to stay in contact with them. And then when they're ready, and we make sure that they ambulate and that they walk about a half mile before they leave, if we're talking about a joint. And then we stay with them digitally or by phone for 365 days. And the reason is just very simple. We want to ensure that they heal well, defined as what they would say, when I heal from this, here's success. Here's what I'd like to do. Wrestle with my kids, get with my grandkids, whatever it may be. And so that entire experience and that we stay in contact with them is just really us bending around them and really making the program be consumer oriented like we'd expect in other parts of our life. And as a result, we consistently get net promoter scores of 97, 98, which really says to us, inside that net promoter score survey, the most important thing is, would you recommend this? Right? And that's what we're looking for, is someone had such a great impact around how this experience and the outcome that they got, that they would say to someone that they love, yeah, you should go do that. So that's what we're after.
Well, and something that we need to make clear, too, is that when they're discharged from the surgery center to the
stay suites
center, it would be equivalent to being discharged home, except it's not like staying in a hospital. It's not that it's a stable patient.
You got it.
But because you're controlling what would normally be happening in the home, you have a much better chance of a better outcome, you guarantee it.
That's right. So part of the, I'll say the tech stack and the technology that we use is to collect really important pieces of information that tell us that we've been very consistent with our provider partners. We know the status, we know the progress, and we know that when we take all of that data, it tells us that we can confidently move them on to the next step. And because we've done this, and the data that's so important in clinical care shows that repeatability and reliability of these outcomes, then we go so far, because we believe that the primary representation of value is that you guarantee your work. And so we wrap a 90-day prospective warranty around that around that care, and that gives, of course, the employers, as the health sponsor for that patient, gives them great confidence, because our data would show that we have significantly lower complications, infection rates, all of those things are top 5% in the nation. But even so, it gives them comfort that there's not going to be additional cost from that. Really that cost of that single event all in is all that they will pay. And that creates comfort for both the employer and the patient.
So talking about what the subject of your upcoming speech, what do you think the challenges are? One thing I should point out is that many, if not most, of the listeners of the podcast are tend to be the freestanding facilities or physician-owned facilities. What do you see in the next 3 to 5 years as the challenges for remaining those fiercely independent surgery centers that are not affiliated? Obviously there's pros and cons of it. So talk a little bit about where you think that the challenges are going to be for those centers.
Well, I think that, number one, we are absolute advocates for the independence. And I believe that because of the changes that are needing to occur in healthcare, that it's not that you cannot have strong relationships with health systems. You can. We have some of those. But you have to make very sure that you have aligned incentives, especially during a time of desired change. Because healthcare is complex, and many of the economic models are deeply ingrained into the motivation for parties. And so we find that independents are strong advocates for change. They want to see their practice grow. They want to see their facility grow, and they want to be rewarded for the great quality that they produce. And we think that the programs that we have and the models that we have that allow them to take on risk safely and benefit from it are part of the answer. And so we want to see the independents remain independent and grow with them. I think some of the challenges that they're going to have to be prepared for is as the voice of consumerism rise and those who pay for care have greater expectations. How, as an independent, will they be prepared to respond to that? So let's just take risk for a moment. It has a lot of different definitions, but let's focus in on anything that would create downside risk for them. How is it that they can lean in and have confidence that both economically and clinically and operationally, they're ready to go down that path if they have greater numbers of employers and thus cases they're asking for that? And we think that is what's going to happen. I think that they need minimally tighten up their operations on efficiencies, cost controls. Those things are paramount. But I think working with someone that is going to have a platform for them to step into that, there's a lot of complexity to healthcare. And I think as any single independent ASC, I think they're going to be looking for someone to help them and guide them through that. The reason one wants to go down that is obviously to grow their business. So a big part of what we do, and I think they're going to need, is how do they take this willingness to adopt programs that have higher quality, higher consumer experience, and potentially the management of risk. You would do that to grow your business. And so what we do is we connect them to a broad network that we take to the employers so that the employers who desire this know where the people who want to do this are. And I think that's a big part of it. In some form or fashion, when you do the things that are going to create greater value for those who are essentially your customers, you need to have a mechanism to make that marketplace aware that you're willing to do that and that you are doing that. I think as an independent, that can be hard, but finding out mechanisms that can make you part of a broader network that creates greater awareness is a strong step that they should consider. Otherwise, you're a bit limited to the catchment that just knows you in your immediate community. And with national employers and regional employers, sometimes where the decision's made is not directly in that community. So one of the things we like to do is make sure that nationally, those that are really willing to go down the value-based care route, that those employers that may not have the decision seat in that same community are aware that in that community where they have employees, there are providers who want to and embrace this model.
And it's a very good point, too, for for those out there that are making decisions, if you exist in a community that has a very large organization that is not based in your community.
Yeah.
And likewise, if you're in a community that doesn't have that, there's probably not a heck of a lot of value. Other than the value that you bring, able to prove the quality, through the systems that you have available.
Yeah, I think that we're going to increasingly see generally payers are going to impose greater quality
measures,
expectations, and I think that even generally that the payers are going to lean in on the experience of and the value of the consumer. So I think we're going to see these characteristics show up from almost anyone who has a fiduciary for the cost of care.
And definitely those organizations that have sophisticated models out there are used, especially those that are self-insured.
Absolutely. I mean, self-insured employers are really the catalyst around this change. And it's because what they clearly know is insurance is not the old-fashioned concept that they're protected. They're not. When those costs go over, they come right back to them.
Absolutely. Don, this has been a pleasure. You got to rush off and actually do the speech now. So thank you so much for joining us.
John, thanks for having me.
My pleasure. Our next discussion was with Eric Evans, who's the CEO for Surgery Partners. During that conference, there was a panel discussion involving national companies that are looking to join Team New York, as they said. And this is kind of innovative for New York. In the past, really, we have a very heavy presence of physician-owned surgery centers. And if there were any partnerships, they generally were with hospital systems. So the influx of the national organizations in the state of New York are relatively new, and that's what the focus of this conversation was with Eric. So let's listen. I'm here at the Fall New York State Association meeting in Tarrytown, New York, and then joining me is Eric Evans. He is the CEO for Surgery Partners. Welcome.
Thanks, John. Glad to be here.
And you just finished a session. I actually don't remember the exact name of the session. I listened to it, but I can't remember the name. Tell us about the title and what your focus was.
Sure. No, it was a real privilege to be able to kick off the keynote here today. And we were just really talking about kind of where the industry is today and what the next 5 years looks like for ASCs.
Absolutely. And so you were talking, the first thing you talked about were the tailwinds of the industry.
That's
so
right.
Mention that, because I think that's a fascinating and something that really resonates not only for our New York listeners, but everybody nationally.
Yeah, no, it really are so many tailwinds. And you think about the three biggest constituents for ASCs, physicians, payers, and patients all meaningfully prefer the ASC setting.
Yeah.
And so you think about from a patient perspective, it's cheaper, it's simpler, they have a better experience. The data shows that.
Right.
For a payer, it's when I go talk to payers, unlike when I was on the hospital side of the business, when I talk to payers today, they're always saying, how can we work together to move more patients to your setting? And then from a physician perspective, it's just their efficiency and their ability to have a voice and actually help drive quality and service. And so you look at those are tremendous tailwinds. And then just from a data standpoint, there's kind of three big things I would point to. One is higher acuity patients coming our way. So you think about technology that now allows things like total hips, total knees, spine, increasingly cardiology, things that 10 years ago you would say that's never going to be done ambulatory,
exactly.
right?
Yeah.
So that's a big one. The second one is just it's becoming a preferred model, even in places where we've been there for a long time, like ophthalmology, GI. You're still seeing that last bit of movement, and quite honestly, it's just becoming a patient preference.
Yeah.
And then lastly, of course, look, we're getting older as a nation, and the increasing aging of our population is a tailwind for the biggest three specialties we talk about right now, which is basically musculoskeletal, GI, and ophthalmology, but increasingly cardiology. All of those procedurally are really tied to age.
Well, and of course, the pandemic caused a huge change. I mean, now people are, it really defined hospitals as those places that you go when you have a very severe situation, and that perhaps who wants to go have an elective procedure anywhere but in a surgery center when you have a risk of, well, there's two parts to that. The risk of getting something that you don't want to get, and also the need for that hospital to be ready to take care of those other types of cases. I mean, that's what a hospital is there for, much more so than doing this outpatient stuff.
I totally agree. I mean, across the country, we saw physicians or surgeons that maybe they couldn't go to the hospital either because of a COVID situation or they were forced to try somewhere new because their patients kind of pushed them.
Yeah.
That was a big change in the last couple of years where they saw like these focused factories, what the differentiation you can do on how you control quality, how you control process, process, how you make it simpler. And with the Hospital Without Walls program that CMS put in place, there were several ASCs across the country that were able to also show, hey, it's not even just about the stuff we do today. There's a lot of this higher acuity stuff that can be safely moved into our setting. So I'm with you. I think COVID actually did change some mindsets. Of course, ASCs have been growing for quite some time, but it does feel like we've got to more of an inflection point where patients realize how many more options they have for things they used to think they had to go to the hospital for.
Right. Well, and they're literally demanding it now.
That's right.
I mean, in many ways, I think one of our marketing mistakes in the past is that we've always said, let's market to our insurance companies, let's market to the doctors.
That's right.
But now we're learning if we market to the patients, they're going to tell the doctors, right from the get-go that this is where I want to be. I don't want to be in that hospital.
Totally agree. One thing I would mention, and it's kind of a little bit unique to us, but we have, actually a lot of the companies have these. We have 19 surgical hospitals, which were physician-owned before the moratorium. Those hospitals, because they're focused factories, they're still way cheaper than the traditional acute care.
Yeah,
and what they allow in combination with ASCs where we have them is it allows a physician-backed way to really do even higher acuity stuff within a service line. And so, I think there's, again, I go back to this idea of when you partner with physicians at the table, it's powerful. It's powerful in the hospital setting because those hospitals, even though they're licensed as hospitals, they have way, way higher satisfaction.
Yeah.
They are focused on one or two things, and they do them extremely well at a lower cost.
Right. Well, which brings up totally off topic here. You were talking about the Hospital Without Walls program, which none of the centers in New York actually went for the program that I can think of, and certainly none of our centers at Ambulatory Healthcare Strategies. But you did have some experience, so I've never actually talked to anybody with some experience on it. Tell me more about that.
We've had a few. I mean, there's requirements. You have to have significant coverage, and so there are expenses you have to put in place to kind of mirror the Medicare requirements to do that. But what it allows for is in that program you get paid at the HOPD Medicare rate,
right?
And you're allowed to do higher acuity procedures than you normally would be able to do on a typical ASC.
Right.
And so for a lot of communities that were hard hit by COVID, it was a favor. I think all of a sudden doctors were like, okay, I can do this, and we've got approval, and it allowed for patients to be treated who needed treatment in a safe environment. And I think it's one of those where we don't have a ton of centers that did it, but the ones that have did it have had such good experiences. I do think for CMS, it's going to be an interesting case study, which is, hey, we did this quite well. We've proven procedures that maybe aren't on the list today are quite safe to be doing. We talked about total shoulders in the session. There are some of these procedures where, long term, it's the right answer for everyone to make sure it's in the setting with the highest value.
What I find fascinating about this program, though, is, of course, any new HOPDs that were developed, past 2016, that were off-site, were reimbursed at the ASC rate, and yet under this Hospital Without Walls are reibused at the HOP. So you literally have surgery centers that have been around long, a while that converted to this, whereas a newer center, is getting a lower reimbursement.
But it was a really interesting answer to some of the pandemic challenges in certain markets.
How are they going to get back to being an ASC? Because that's one thing I've heard there is some complications with that.
Yeah, so I think, the challenge, I think the complications are all of a sudden things they were able to do for a period of time, they can't do all of them anymore. And so I think it creates pressure from the physician side. And certainly, there will be it'll be a financial step back, but we don't anticipate that being a problem. What we saw it as just a really nice experiment and to show what ASCs are capable of. And, we were proud to also be part of the solution, obviously, during the pandemic. So.
Yeah, and I think we actually really should probably document that whole exercise, get some speech, because we all know this is going to happen again, unfortunately. And I think that that's definitely was a wonderful solution. Talk a little bit about cardiology, because it's one of those areas I'm fascinated. Of course, we're sitting in New York right now, but of course we have a national audience, which will also probably hear your speech. But for those of you that are not aware in New York, cardiology is not allowed yet. But talk about tailwinds, huh? Sure.
Yeah, so cardiology is one of those specialties that I think it should have been in the ASC space a long time ago, but I'm glad it's here now. So having, I spent a lot of my career in the acute care world, and, it's probably 15, 20 years ago, it was pretty well understood that hospitals could have large and successful and safe interventional cardiology programs without open heart backup. And, that kind of was the time period where you could have argued that, okay, well, this should be done in ASCs. And in fact, one of the markets I worked in, El Paso, Texas, years ago, they had freestanding ASCs that were doing, PCIs with commercial patients, but not with Medicare. So this has been around a long time. I think the government, so the reason CMS approved it is quite honestly, the efficacy has been proven. These patients They go home same day. They have great outcomes. And if you think about, we talked a little bit about the size of our market. It's a $150 billion market if you look 5 years ahead. So today it's $90 billion. About $35 billion of that $90 billion of outpatient surgery is done in ASCs. But that 90 grows to 150 with the introduction of high-end orthopedics and cardiology. And so we just see a tremendous opportunity for savings. You'll recall the slide. I mean, almost everything in Medicare is 50% cheaper, at least in the ASC setting. So I'm extremely excited about what can happen in cardiology. And look, the way the technology is changing, and I referenced this, I mean, there are procedures that 10 years ago, if you had to have a valve replacement, you would have to have your chest cracked, and it would be a huge ordeal. Now that procedure, the TAVR procedures, it's happening in hospital outpatient departments, and many of those patients are able to go home within 24 hours. And I just think the technology, we have this kind of vision of what ASCs can be based on today's technology, but I never dreamed 5 years ago what's now in the outpatient setting. And so I actually think, we're probably conservative, because I think there are going to be more and more things that will allow patients to be treated successfully with great outcomes in our setting.
Absolutely. I just saw a total hip for the first time probably about 6 months ago. I remember my mother having that procedure, 15 years ago, and was in the hospital for, more than a week.
Yep.
And I had to see this procedure. I just couldn't believe it could be done. And it was incredible. And it was incredibly fast, too, which is even more amazing. You had a slide up about, which I thought was fascinating, 500,000 people and the $30 billion. You were talk about that more,
Yeah, I mean, so I think one thing that's changed in the ASC space as higher acuity procedures are starting to come over. So, GI, ophthalmology, those early ENT, those early procedures, they would save significant money, but on a per procedure basis, in the big picture of a payer, didn't move the needle necessarily.
Yeah.
Now, when you're talking about hips, knees, spine, cardiology, it's often $10,000 to $30,000 a procedure difference.
Yeah.
And so when you're a payer, you're thinking about, or you're an employer, and you think about, gosh, I have a lot of these procedures, I can save 50% in a system right now. As we know, the math's really hard, right? Like healthcare is too expensive in this country. We are uniquely positioned to be part of that solution. And so, I mean, you look at I even just look at our system. We have 120 ASCs, 19 surgical hospitals. We did our best estimate looking at kind of, if we weren't in those markets, what would the alternatives be? And our savings for the system is about $1 billion. And so you sit there and you say, why shouldn't more of this stuff move? And as it does, that 500,000 people being treated and saving, tens and tens of billions, it's a big deal. And one thing I'd say for everybody in the ASC industry, what's great about our industry is you can be somewhere where we're going to grow and do good, but we're going to do well. But we're most importantly, we are part of the answer. Like this is important for consumers. It's important for access. And I did give a shout out to New York in my comments, because this is a state where, because the dollar follows the patient, Medicaid patients can be treated in the appropriate space. And I'm really hoping nationally they can look at the model in New York, because right now in most states, just because of the way the dollars are funded, the patients in Medicaid programs often get treated in the highest cost places and not necessarily the best cases for them.
That's right, right. Yeah. Absolutely. That's a very good point about New York. And, the Medicaid program is actually pretty good here compared to other locations. You're also talking about specifically the New York growth. Of course, I founded the New York State Association. I've been around for a long time. And, when we founded it in 1990, imagine that the New York, experience has only been 32 years old now. And of course, at that time, there were 20 centers and 6 people sitting. We're recording this in a boardroom here, and we had a room like this now. And of course, look at the number of people out there. But we're still not there, aren't we?
No. I mean, it's interesting. I think you look at New York and you say, gosh, 31 years ago, there was a lot of forward-thinking people, and unfortunately for New Yorkers, and I think this is going to catch up. But we mentioned on the presentation, and one of the lower per capita kind of ASC states in the country. So the opportunity is huge for savings, for the right answer for patients. And so I think it's not just New York. There's a lot of states that still have opportunity. We had a slide that showed, there's roughly 6,000 ASCs today. It's going to grow by 1,000 over the next 7 years. I mean, there's just a tremendous amount of focus on this. And I think New York stands to, as a state, stands to benefit in tremendous ways as your group and as the industry grows.
So now, of course, a lot of our listeners are independent ASCs, fiercely independent ASCs.
Yep.
But of course, you come from the big company, and of course, my company, of course, is pretty big in a different side. But so it's interesting. Of course, we're kind of on opposite sides, the corporate model versus the fiercely independent model. But let's face it, there's room, obviously, for both. We've been coexisting for a long period of time here. And I'm fascinated by where we're heading and how there'll be more partnerships between those different models. Talk a little bit about that.
Yeah, no, I think, look, I understand that most physicians who have chosen to go and found an ASC, they're independent by nature, right? They've already proven that they want to have control, they want to do things their way. And I will say we wouldn't have 150, 60 partnerships with physicians if we didn't understand that it truly has to be a partnership.
Yeah.
I think in our world, I would point out for us, 98% of our revenue is just two-way partnerships, just us and docs. And so our sweet spot is we partner with independent physicians, and the only way that works is if we bring real value. So we don't partner to buy and flip. We partner to buy and own forever. And so we all together collectively say, what can we do together where we can bring additional resources? Sometimes it's things like supply chain, having national scale and scope. Sometimes it's things like being able to bring in certain clinical resources to drive acuity. It's a number of areas where we feel like we can help, but that only works if there's additional value. Yeah. And it only works if there's a partnership where you can really, partnerships are in many ways like marriages. Like you have to run at conflict. Like if there's something that doesn't work, you have to have a partner where you can sit down and get through those things. The one thing we've learned after 150 of those is that number one, you always end up with a better answer with the physicians at the table with you.
Yeah.
But there's a lot of we don't drive one model because honestly, one model doesn't work in our world.
Well said.
And so for us, we try to find that sweet spot. But we understand. Look, there are some centers that aren't ready for that, and honestly, they're fiercely independent. There are others that say, gosh, I know what's happening in my market, and with the level of capital and with the speed of the change, I think I need some help, but I still want to be a big part of it. And I think we try to be that. Our goal really is to enable independent physicians to stay independent, and we think that's a really important thing. And we do think the speed, the scale, and the investment starting to change in the industry in a way where I think partnership's more important than ever. And I mentioned our mission statement is to enhance patient quality of life through partnership. So everything we do is through partnership, which means that while we have a voice, really, again, the physicians are what allows this industry to have such great service and quality scores. And so we understand, like at the end of the day, how you win in this game is to find the right partners and build long-term partnerships.
I love the fact that almost every other word that you say is partners. It's funny. I'm probably going to have Sue add up the number of times you use partners, even in your speech. Yeah. But that is so critical, and I think that's really perhaps the secret. It's right in your name, obviously. It's a secret to your success. There was a recent study done that found that hospitals are less and less frequently partnering with these big companies out there, management companies, which I thought was interesting. And I was trying to think, what is the future? Does that mean that management companies won't have the force? But you just kind of talked about, that as hospitals get this niche over here, this surgical niche over here is going to be, the purview of companies like yours.
Yeah, it's really interesting for hospitals. We are talking with some hospital systems. We will do some partnerships with like-minded health systems that aren't looking just to kind of slowly kind of keep things the same.
Right.
And so for us, it's really about that. But, I will say this, having been a hospital CEO for a lot of my career and run big hospital systems, it's really hard for a hospital system to run a big, all things to all people hospital system, take their hat off, go to a kind of a rounding error small facility and suddenly have a different interaction. Yeah. And so that's where you've seen, they've been talking about for a long time, partnering, but it's hard. And that's why often they need a middleman or they need someone that can kind of do that. Now, look, there are systems that have done it successfully, but it's a mind shift change. I think the good news is because the ASC industry is starting to gain so much traction, hospitals will be forced to be be better for physicians.
And figure out how to leave them alone.
Right. That's right.
We have hospital we don't have partners, but we work with hospitals also in this space. And the challenge we always have with them is they think they can bring something to the table to enhance the outpatient experience, whereas we say, no, I think we can bring something to you that you may be able to use to enhance your experience in the surgery side.
When you're that big and you've been around that long, there's a level of arrogance that
there is
creep into it. But I would say, too, this is another chance for me, our 19 surgical hospitals, what's interesting about them is what it allows physicians to do is to have the full range in a physician-owned environment, the full range of services where they're able to be in the ASC, they're able to be in the hospital, and they actually, it kind of empowers them because they're not dependent on a hospital that way. They have their own kind of hospital where they can do things. So I think but again, having been in the hospital world a long time, I have a lot of sympathy for what they're up against. And I think they're increasingly realizing that the path forward has to be different, and they have to start changing their model.
I agree. Unfortunately, my background is hospital. I don't say it. It's interesting how you're still admitting that, out there.
Look, there's amazing people in the industry, and obviously, at the end of the day, we need hospitals.
Yeah.
But we need hospitals to play the role that they can play best.
That's so well said. And I think that's the big thing that hopefully everybody learned from COVID. It has been frustrating to me that I think there are pockets where they literally don't get it. We have hospital systems in parts of New York, for example. They're running at 100% capacity right now, and it's not even flu season yet. Yeah. What did we learn? They should be shifting those cases out.
Yeah, what's so frustrating there too is you see hospitals. I always say they have an edifice complex. They love building big buildings, right? And part of the problem with that is you can imagine in a place where the hospitals are 100% full. The right answer is take the lower acuity stuff, get it to the right side of care. But often the answer is they build more expensive buildings. And so I think hopefully we're getting to this point where that just rationally, you don't need to do that, because the answer really is use the right value, right location. And, some systems are more progressive than others.
Absolutely. Yeah. Eric, this has been a pleasure. Thank you so much for your time, and thanks for making the trek out to New York.
Thank you, John. Really enjoyed it.
Thank you. The next interview was with Emblem Health. Emblem Health is an insurance company working in the state of New York, and they had an administrative panel discussion during the conference entitled How to Team Up with Payers, a Roadmap. And I had an opportunity to talk to Carol Huffman, who's Vice President of Strategic Partnerships with Emblem Health, and Lama Elzain, MD, who is the Senior Medical Director of Emblem Health. So let's listen to that interview. So this is John Goehle. We're here at the September 2022 Fall Conference for the New York State Association of Ambulatory Surgery Centers in Tarrytown, New York. And I have with me from Emblem Health, and we're going to be talking about insurance and the relationship between insurance companies and the surgery center industry. I'd like to have everybody introduce themselves.
I'm Lama Elzain. I'm the Senior Medical Director for Population Health and Quality at Emblem, and I'm a practicing physician.
I'm Carol Huffman. I'm the Vice President of Strategic Partnerships at Emblem Health.
Thank you.
And I'm Doug Vasquez. I am the project manager leader for Emblem Health.
And so I'm recording this just after you finished a administrative panel, one of our panel discussions here at the conference on how to team up with payers, a roadmap. So you did a great job. I was not there for the whole session, so we did quickly go through, and we've been doing a lot of recordings here. So can you give me a brief overview of what topics you covered? And then we're going to go into some of the nitty-gritty, because there's really some great information that you provided.
Yes. First, we really covered the concept of low-value care and high-value care. And that was because we wanted to make sure that the ambulatory surgery centers understood that they are really high-value care. Mm-hmm. And high-value care is important for the whole ecosystem, the whole healthcare ecosystem to thrive. And that's really the first thing we covered. Then we covered the important aspects of an ambulatory surgery center from their perspective, and then also the health plan's perspective, and the importance of having a partner. To be a partner, you have to have a partner. Mm-hmm. So we talked about having courage to talk to each other and work to each other as partners in order to really help make sure that high-value care is achieved.
And you're using a term that, by the way, so this is probably our 7th interview that we've had during this thing. And it's so funny. A couple of the other people, if I were to have somebody count the number of times partner or partnership was used in this conference, it would be by far the most widely used terminology here. And of course, many times I'm an accountant. So when we talk about partnerships, we talk about that financial partnership. But that is not what we're talking about here, because we're not necessarily talking about a financial relationship. We're talking about an interdependent relationship. So talk about how you can build that type of a relationship with the ambulatory surgery centers and the importance of it.
Yeah. So I think it's important that we're talking here about clinical partnership.
Yes.
This is a healthcare, issue and a healthcare.
We're not selling widgets.
Yeah, exactly. So patients first, and it really, patients was always first, but now with the ever-changing healthcare system around us and all the policies, the healthcare organization of tomorrow needs to understand that, whether you are a payer, whether you are a provider, whether you are, selling things for the healthcare industry, or whether you are a hospital, this is the patient is and should and was always, but should be the center.
Right.
And this is why we talked here about clinical partnership. I think in one of the last lecture about safety, they were saying, finances are important, but your culture in your healthcare organization should be, your clinical first, patient first, your staff, your team, and finance, of course, is there because, if you don't pay people, no one will work for you. But when the first 3 or 4, part of your culture are focused on the patient and the team, the finances will fall in place.
Right.
And this is what's important about the partnership. It's both sides. We need to have the clinical partnership and the administrator partnership all together to be able to have a good project. And one of them is here, as you see, the many partnership you have for ASC.
Right.
And I'll add to that it's really important for society and for all of us to try to spend the healthcare dollar wisely.
Yeah.
And so a lot of what we talked about today was it's so important for ourselves, our friends, our family, our businesses.
It's very personal.
Yes.
I mean, it's exactly what we unlike so many other products, we are all consumers of the product that we're talking about.
That's right.
Here.
And we called it a bucket of money. We have a bucket of money and we have this to spend together. We want to work together to spend it in the most efficient way so that we can address important things like healthcare equity, like access.
Mm-hmm.
If you're in an ambulatory surgery center for your procedure, chances are you're going to get in earlier.
Yeah.
It's going to take less time. Your outcomes will be better. And so let's use the hospitals for what they're good at.
Yeah.
Let's use the ambulatory surgery centers for what they're good at. And let's use primary care for what they're good at. Let's just work together. I think, Lama, you said it best when you said the healthcare ecosystem of the future doesn't have enemies.
Yeah.
So maybe you could just say that one more time. I think that was so important.
Yeah.
I mean, as we know all, the healthcare system here is so, divided and fragmented. And part of it is like each industry, even if we are all under healthcare, but there's like many industries. So the ambulatory care surgery centers, hospital, physician,
nursing homes,
the nurse, the nursing staff. Then if you talk about the bigger, the nursing home, the home care, each one has their own kind of, agenda, but also their own roles and responsibilities. Right. And in the past, it was like, each will do their own job, and then that's it. I did my own job. If there's something went wrong, it's with the other, right? So, so that doesn't work anymore because really we saw where we are, where our population health outcome from that kind of fragmented care. Yeah. It's not going to be a magic wand where things going to be changed and everything is the world is happier place.
It's not going to happen overnight.
Yeah, exactly. It's not going to happen overnight. And this is what we talked about small steps, partnership. We're not talking coming the first week and saying we're going to do the best value-based agreements and then it's going to be the highest quality. I mean, there's a lot of barrier. We have to be realistic. Right. But we start with baby steps. The first one, baby steps in communication. Even from a health plan perspective versus a hospital partner and ambulatory care surgeries partners, let's sit together and see how we can help together just with basic communication, with basic escalation. If there's a patient's issue or if there's a prior auth issue or if there is, you need something from the PCP, let's get those partners on the table and just have each other's number maybe as a first step and know about each other and know what each other's role is and how can we help each other. And once we have this kind of cultures of be open and not thinking of the others as the enemy, we will go to the next step. And the second one is, but also not everyone is on the same page due to maybe IT issue, maybe due to, culture issue, resources issue, so understanding and aligning incentive is very important. Finding partners who are thinking the same way, even if they're not there yet, but they want to go there. So aligning on those kind of what drive you, what's your culture, aligning financial incentive with clinical programs is very important. You can have the best clinical resources and doctors and nurses, but if your financial model doesn't support that,
Right.
you cannot
incentives are
survive,
not gonna
right?
be there.
And
Yeah.
then if you have, a lot of money and resources, but your culture and your clinical program doesn't support or doesn't align with that, also is not going to be successful. And at the end, what we are interested in as a health plan, and me from a clinical perspective in a health plan, is clinical outcome. And once we have these starting to align together and have a better communication, I think some of the inefficiency will decrease, and then we will start seeing better and better outcome. And our population health outcome as a population in the United States will improve.
As the industry has evolved, when I got into it some 30 years ago, the insurance companies had a completely different attitude. And not to pick on you poor guys, but because obviously you've evolved, as have we. We've all evolved in this over those years. And I still remember those conversations at the beginning. It was really all about money on your side and utilization review. And most of the people that were involved, the medical directors in the organizations, the physicians, and it was all about utilization review. Get them in, get them out. Get over it. Tell me about how those things have evolved in your lifetime, your career also, as well as how it is continuing to evolve now.
So I have also been in the healthcare system for over 35 years, and you're absolutely correct. I think that one of the ways that health insurance is evolving is around value-based insurance design. And that allows us to be more accountable for working with employers and our clients to build product designs that incentivize people to do the right thing, incentivize the member, incentivize the providers in a positive way to really take control of how they navigate the healthcare system, allowing it to be easier to navigate. That's really our job.
Right.
And to make sure we have all the right tools in the toolbox for the providers so they can make sure that their patients are getting the right care at the right time in the right setting.
Yeah, I totally agree, Carol. And one thing I think is important, it's not a happy picture. It's still, there's different health plan with different, culture. But one of the things, what we are trying to push, and especially in the last couple of years, we are in a transformation. And many other plans also are in a transformation.
The whole industry.
The whole industry. We have to understand, again, that healthcare cannot continue like that.
Yeah.
That's one. That patients are not and should not be passive in receiving their care. They're very active. There's a center. And then now in this kind of Amazon, Walmart, all of this kind of, word, we have to think differently. The patient is thinking differently. We have their satisfaction is important, and as well as the quality metrics, as well as the finances. But those are three. And then the patient comes first and the quality comes first. And then even with the CMS guidance and all of the quality kind of guidance, they're pushing towards patient satisfaction. So our patients are at the centers of what we do. So the other transformation that I want to talk also about is, traditionally as you said, it was about utilization management, but it didn't reach anywhere, right? It reached that there is more kind of opposition between the different health sector. So we have to think about it differently. Exactly.
Quality.
It's just you do their own thing. We do, the health plan do their own thing. They approve, they deny, whatever that is. Minimal communication, and who's not benefiting from that? Our patients, our quality outcomes. So we have to think differently. And what we're trying to do in the last couple of years is, to try to depend less on utilization management, but more on partnership. We don't want to tell physician, I'm a physician myself, and I hate it, and I still hate it to this day. Even sometimes with my own plan, I got frustrated. I mean, we have to paint the reality, but that, we don't have to dictate the patient-doctor relationship. On the contrary, we want to enhance it, and we want to let the patient be patient and the doctor be doctor, and we're here to support. And part of the example we gave this morning with the different partnership we presented is this is what we want. We listened. Okay, we listened. We bring partner together from surgeon, ambulatory care center, hospitals, PCPs, because these are all the corner represented in a patient journey. And then we kind of moved around the patient journey and then see how we can partner together to have better quality outcome. And this, we didn't talk about any utilization, management. We want to try to move away from that. Even in many other setting, we are moving away from that to kind of decrease administrative burden, which is a big part of why healthcare has a waste in the United States.
Yeah, it's really about removing the cost between and within systems, and that's the administrative burden that we're trying to address. Yeah. And I think the other thing that we're trying to address is eliminating the low value care from the system and replacing it with a high value care mentality. So, for example, today we had an eye surgery come to us, and we just had a little brainstorm about dropping the pre-op for cataract surgery. Yeah. That's unnecessary. She said that would actually help with their no-show rate, and maybe what we could do is substitute something of high value, which might be diabetic eye exams. And so that's the type of partnership that's true clinical partnership that a medical director of population health. And I would recommend that surgery centers and others try to seek out the population health lead, because that's usually going to be a clinical doctor like Dr. Elzan, who's really forward thinking about these clinical programs. And that's, if I were going to give advice, I don't know, Lama, if you would agree, but that's who I would think that folks should try to be seeking out in the health plans of today and tomorrow.
And that actually leads me to perhaps our last question, which is most of our listeners, nationally as well as in the state, tend to be the small centers. We have national organizations too, but they're the smaller centers that, they don't have those huge departments that are handling the relationships with the payers as well as they have the same problem with it, from a compliance standpoint and regulatory standpoint. So what is your message to them? How do they get known to these organizations? I think we know that in the long term, there's probably going to have to be a movement toward more collaborative relationships among them, that these independents are going to have a harder time surviving, but that doesn't mean that they are completely out of the picture. How do they interface with the emblems of the world?
Well, I think that they should. Lisa, who's working with the organization.
Lisa Altieri
she gave some great advice today, and I'll just reiterate it. It's preparing for the future, telling your story, writing your press release now, and then build to that press release. Yeah. Say you write your press release now for 1 year out, build up to that, and then seek out those payers and other partners that you see maybe on the web, in the news, that look like they're forward thinking around these programs. Seek them out and really come to the table with your story. And Lama, I think you said it too. Come to the table with your data, whatever you can collect.
Yeah, whatever. It doesn't have to be, the best, IT and you know your data. And I know the most independent surgery center know their data. Come to the clinical team, as I said, through your contacts, through the people who do the contracting. Ask for your medical leadership to meet the medical leadership in the health plan. Come with the data, just put it on a piece of paper, good data, tell your member's story, and then, seek for help. Like what exactly the short-term plan, what do you need to be able to survive and continue to serve your patients and show this quality. And then they will listen, and then they will start supporting, and then they will bring the financial people in kind of new, innovative way that other people are doing that we can implement on a smaller scale. It doesn't have to be a bigger scale. And Emblem is also not one of the bigger national, gurus of insurance. We are also a local healthcare insurance in the tri-state area focused in New York. You might have other partners that are local or national, but, you have to seek that culture and that kind of mirror culture in the partners that, that you're going to work together, and it's going to be a road. We said it today. It's going to be a road. We have a roadmap for it because it's not going to be tomorrow. It's not going to be in 6 months, but small steps and small gains.
Well, and that brings me to an important point for our listeners is that we talk a lot about the regulatory need for quality improvement. We talk a lot about the importance of making sure that we have good information for our quality improvement meetings, that when the surveyors come out, everything's going to be perfect. But that's the regulatory side of it. And then there's a legal side to it also. But what is often forgotten, especially, and I'm sorry, I'm looking at you because you're a doctor, but you obviously are a forward-thinking doctor. Many doctors out there hate this quality improvement process. It's not that they don't want high quality care. They don't like the process they have to go through in order to get to that end. Many start with the thing, I always provide high quality care. Well, those of us in the regulatory, I'm on the regulatory side, we want to see the data. We want to prove it. And yet here's another example of why that information is important. And that's the sea change that's occurring in our industry right now. Is never before has there been this real push from the insurance companies to get a hold of that data that we have been accumulating over all these times. And one of the things that we forget here is how important our internal and external benchmarking data is to this, and keeping that up to date, using technology as much as you can. And I love what you're just saying about it doesn't have to be a lot of data. That's interesting, Lama, because I sometimes we think we have to develop these extraordinarily complex systems, and yet sometimes you just want a simple answer to a relatively simple question to see what we're trying to accomplish.
And one thing you said about physician, also our, healthcare frontline, are burned out, and we have to take that into consideration. They were burned out before the pandemic, and now even more.
Even more so,
right? Because all of these regulatory, which I'm not saying they're wrong, but they fell on their shoulders.
Yeah.
They have to provide patient care. And then I said in the panel that our chief medical officer always say, let physician be physician. Yeah. And that's our role from the healthcare, but also the administrator role for example, the ambulatory care surgery, to kind of work with the physician. The physician is going to do the best care. As I said, I do a high quality surgery for my patients, right? Yeah. So, but help support them to kind of make the workflow that is regulatory and for safety precaution, make it easier in the EMR, for example. Yeah. Make it in the workflow so that they don't actively have to think about every single step except the patient surgery, right? Yeah. Yeah. So that is the difference, and that's what sometimes in certain healthcare organization, the burden of patient care plus the others, all of the check marks of the quality has fallen on the physician or nurses, and they burned out. Yeah. When you take that administrative component and make it just flow within their workflow, it makes it you will find partners that are willing to help and willing to improve. And the whole culture of safety and quality will improve in your organization.
And it helps you to get to the point where you're not looking at the data, you're looking at the conclusions that come out of that data.
The insights.
Exactly.
That's right.
And we need the data to reflect what's going on, right? And this is why we don't want to sophisticated data that if, in a way or another might kind of hide what's going on behind, right? Yeah. We need to reflect really the patient experience, and we know there's a barrier, right? Yeah. And we know what are the success and what are the failure, and some of the failure might be barrier from the insurance company. Right. Also, we have to self-evaluate ourselves and then come to the table with an open mind that we all need to change. We all have our failures, and we need to change and move it to the next step.
Yeah, my listeners have heard this story, unfortunately, many times over time, and you get to this point. When I first started in the 90s, I'm a data geek. I taught statistics in college, so I want all this data. So we had 150 data elements, and our second survey, the surveyor came out and said, "This is all well and good, but this is trash." No, it isn't. And what she says is, it's not relevant data to what we're looking at. Pick 5 of those things and focus on those 5. And that's exactly what she said. And that's a message that I'm actually starting to feel that maybe I've kind of forgotten, since my first experiences with it, because the regulators require us to have certain elements. Now, they're not really telling us what they need to be, but sometimes we just want to cover all our bases, make sure it's all there. And I think your insight there is extremely important. And it's good to hear insurance companies out there. It's even hard to call you insurance companies anymore, isn't it? Because we're really in a completely different world where there really are these true partnerships between the providers and the payers out there. So,
and Emblem Health is really different.
Yeah.
Like Lama said, we are not for profit.
Yeah.
Our family of companies includes Advantage Care Physicians of New York, which is primary and specialty care, 40 centers in all of the boroughs on Long Island. We have Bronx Docs, which is also part of our family of companies. We have Connecticut in Connecticut.
Oh, wow. Yeah.
We have Neighborhood Care, and we have WellSpark Health, which is our very important wellness national company. And so we are different. And I think because we have so many of the pieces of the healthcare system perspective within our vertical, that we have become a leader, a thought leader in this regard. Our CEO, Karen Ignani, is a true visionary. And we serve the city of New York workers. We work for them. And so we take this very seriously. And as a not-for-profit, we are able to, instead of focusing on shareholder value, we're focused on the member value and our customer value. So we are different, but we do see the trend and the tide turning in our industry, as Lama says.
Thank you so much for your time. I really appreciate it. It's been great.
Thank you.
In the next interview, John speaks with Todd Logan, the Chief Growth Officer of Surgical Information Systems.
And Todd's been with us quite a number of times during the podcast. And, of course, SIS is one of our sponsors of the program. And as always, it's always a delight talking to Todd. And in this particular case, we were talking about the future of technology in the surgery center settings, and specifically why it's probably time for electronic medical records to come into the surgery center setting. So let's listen. So I'm here at the New York State Association meeting in Tarrytown. It is September of 2022. Todd, can you believe it?
I cannot.
Oh, my goodness. So I'm here with my dear friend Todd Logan, who has been on this podcast. I think if we were to actually list the number of times certain individuals have been on the podcast, probably you would be toward the top end of that. So welcome back.
You're going to be charging me rent here.
Yeah, that's right. Exactly.
Sure,
So,
yes.
And the funny thing is, as we were talking beforehand, is what can we talk about that we haven't really already addressed? So I just threw an idea out there. And actually, you just did a presentation with some other vendors in the EHR space about, what is, I think the title was "The Future is Digital, Why You Need EHR." So we've talked so much about that during the podcast that I thought maybe it's just an interesting thing that you got a lot of experience with implementing them. And, I think we all agree you got to move to an EHR. So given that, maybe we have to think about, let's make sure we're totally prepared for the challenges, because we know what they are, but we don't always talk about them. So why don't you just talk a little bit about some of the implementation challenges that you've run into in the last year, especially recently, post-pandemic and, with supply chain and all the other challenges, limited number of staff, et cetera. So that just like it really current to what's going on, within the last even 6 months.
Absolutely. And thanks for the opportunity, John. Always great to see you, and
Same here.
Great opportunity to be able to have this discussion. And actually, I'm going to go back a little bit further, because I think this might be relevant to the discussion.
Sure.
Because I think I shared in the presentation today that I have now been working in trying to persuade and trying to enable ASCs to adopt EMRs for over 20 years.
Yeah.
And as we go through this, I have not been doing this consecutive years, because about 10 years ago, I had the opportunity to go work for a management company, and we managed about a dozen ASCs and surgical hospitals. And I was thrust into a role out of necessity for the organization to be the administrator of a multi-specialty surgery center.
Yeah.
And why I bring this up is I stepped into a situation where it was an EHR implementation gone wrong.
Yeah.
So I really love the saying that success is a poor teacher.
Yeah.
I had a really good teacher in that this was failing miserably.
Yeah,
so
right.
I got to be able to experience firsthand what to do right and what to do wrong. And
Not so good for the client, for the place you were working for, but great for the ones that succeeded.
For my own personal experience. Right. Yeah. So I think in retrospect, when I look back on it and what went wrong, what wasn't successful, or what were the lessons learned, was really the fact that there wasn't executive support.
Yeah.
It all starts with executive support. And we all know that working in surgery centers, that we can show up and do a fantastic job supporting the surgeons and all the providers day in, day out, and do a great job in that regard. But if there isn't executive support from the surgeons themselves, it can sabotage any project.
Right.
They got bored with it really early on. They saw some things that it required them to do work on, and they said, this just seems like more than what I wanted to sign up for. Can we just push it off?
Yeah.
Can we just push it off? And then that is that's something that's really hard to recover from, because there's never a good time for it if you don't have that executive leadership. So,
and I think to that end too, when physicians have to be in that mix, which they have to be for the training, they do not want to sit through a 3-hour training program. They want you to give it to you in 30 seconds. I mean, I guess I'm not really kidding when I say 30 seconds. I want log me in, show me how to get to where I need to be, and then I'm done. You've got to find a way to get them hooked.
We don't have the luxury of saying, come to this training class for 8 hours at the hospital or you lose your privileges.
That's right. That's exactly right. Yeah.
They demand their own privileges.
Yeah, that's right.
It's their center. So no, we don't have that. So it's incumbent upon the vendors to obviously make the solutions incredibly intuitive,
right,
so that they can adopt it. And for the most part, I think that's one of the elements of feedback that we get from our users, whether it's surgeons or it's anesthesia providers that are coming in. Obviously, anesthesia is a big one. They're contract workers; they've never seen this thing before,
right?
And they can really really get the hang of it in just a few minutes.
And of course, they in many cases work in multiple environments.
Yeah.
That have no commonality. Work in a hospital with, one of the big systems out there, work in a surgery center with a small one, and probably working in an office-based practice with none at all. So,
No, you're absolutely right. So that's one element of just making certain that the system is intuitive enough to be able to inform them and be able to really adopt the system in an easy way without formal training, because formal training will not happen for the most part,
right,
by a lot of the surgeon and anesthesia providers.
So, as you've looked in the last year, what do you have a implementation nightmare? Other than your own personal experience.
Right. So we started.
Please don't name me any names. No, I'm kidding.
I wanted to start just trying to establish a relevance of my personal experience, but you had also said, what has changed post pandemic? What has changed in this discussion? What are we seeing as far as some of the elements that surgery centers are struggling from? And a lot of it right now is we have to adapt around staffing shortages.
Yeah, well said.
Right.
Yeah.
So we have people who have decided that in the past year or two, for all the right reasons, they want to move forward with the new system. They want to move forward with electronic medical records. But now they've had transition in some of their staff. Yeah. And maybe some of those champions who were there before are no longer there. And they just really don't have the bandwidth to do this. So we've come up with some creative ideas for them. We're using a lot of third-party consultants to come on in and help understand their environment, consultants who have helped build solutions before. And they can step in and they really add a lot of value because they know some of these inherently what some of the pitfalls are, and they know what questions to ask, and they can quickly see some of the workflows at the facility and translate that then into how to best optimize the solution when they're doing this rollout.
Yeah, you bring up an important point too, is that initial training that you provide, it's like you go in and you feel, well, I'm going to train you. It's almost like our boot camp. We go in and we train people in 4 days on everything, but we know it doesn't stop there. They have to, that's why we give access to people to be able to read it, watch it over and over again. That's where you have had to adapt to be able to provide training in multiple ways, not only on site or virtually, but also through recordings of that. So you've had to adapt to that, as well as to adapt to different learning styles.
Yeah, absolutely. And we call it just-in-time training.
Yeah.
Because you can sit through formal training, formal classes, and it's all great when you're watching it on a screen and somebody else. But unless it's your data, unless it's your system, unless you're actually doing patient care that day, and you have to chart it, it's really hard to retain that. So we take that into consideration. And we have built-in tutorials within the solution and say, hey, remind me how I started an IV in a patient. And then it has a little pop-up that'll kind of walk through and just say, here are the steps to start an IV in a patient. And here's how you document that element of it. So we have that. And obviously, I mean, it's been challenging for us too. I think the pandemic, what it did, we already had momentum going into the pandemic, but the things that changed are that people no longer had access to their solutions if they were housed at the surgery center. And then they were opening for a few days, closing for a few days, closing for a week or two, et cetera. So then they realized that, hey, we need a better way to access our system. We need a cloud-based solution, which we're happy to really educate them on and move them in that direction of our new solution. But part of that has been challenging for us too, just because we're really proud of the fact that we're the fastest growing ASC solution of all time, right? Just surpassing our 500th unit in just a few short years. So it's really exciting, this growth, but it does put some training and education constraints on our organization because we are moving so fast. Yeah,
and that actually brings up a very important point, is that as the adoption rate escalates, and that's what we're seeing, is that growth curve is no longer linear. It's becoming, it's starting to head toward the exponential. You're going to have a harder time getting in the loop. You and I have been saying this for a while, sooner rather than later on this. And there's some organizations that, I think somebody said during that speech, that session that you had this morning, that there are some people out there that are just not going to implement this until the law says they have to, and we have to respect that, of course. But it's going to be harder for them to make that argument as insurance companies, as the the end user, as a government requires much more information that you just can't get off of a paper system.
Yeah, absolutely, and a couple of things since the last time that we talked. This is new content now. We can go to new content of some of the elements that we've seen. Is I had never seen this before, John, and that I was meeting with a CIO of a large healthcare aggregator on more than 100 centers. And a gentleman had explained to me, he said, I've never heard this before, right? Surgeons in the past have been running away from EMRs. They don't like the one they use in the hospital. They might not like the one they use in their physician office. And this is the last place where they don't have to use one.
Right.
But we're seeing a change. He said in the past month, he actually had 2 separate surgeons in completely different geographic markets come to him and say, I don't want to bring my case to your center because you don't have an EMR. I'm just not going to chart on paper and use dictation. I'm just used to having templates and having this all automated and logging onto my phone to sign off on my order sets and sign off on op reports and be able to do this. It's really inconvenient for me. So it's taking a step back. And I think that we're seeing this as a change as new surgeons are going through their schooling, just clinicians in general. They've just never had to interact with paper before. And then they start out maybe in the hospital, in another care setting, everything is electronic. They step into a surgery center. It's like stepping into a time machine. How do I, where's the on button on this piece of paper? I don't understand. How do I log in? So I think
you have to be guided through it with somebody. I mean, literally the nurse is going to be standing next to you, showing you where to sign and all that. Whereas with an EMR, the system is helping you guide you right through it, and in many cases won't let you go anywhere else until you signed off on something, which a piece of paper is not going to do. And I think we always end with this type of a conversation, but the importance of having a solution that is geared toward the ASC market. Now, we often talk about some of those lesser systems out there that might have been designed for offices. I'm going to go the other way this time, which I don't know we talked about here, in that we've been working with some hospitals recently that own surgery centers or have purchased surgery centers or are, running surgery centers suddenly. And they're saying, I'm not going to go out and buy a system designed for a surgery center because I've got this wonderful system from the hospital and we'll just put it over in the surgery center. And what a nightmare that has been for those clients that are doing that and the inability for those systems to either flex for, the much lesser environment, and some of the questions that have to be asked because the system does it. Like, you come in for cataract surgery, and one of the questions is, in the last 30 days, have you ever felt like you wanted to kill yourself, or suicide? It's like, I don't think I'm going to ask my patient that question, but those are things that are built into a hospital system that have a different set of regulations and a different, and of course you're taking so much time to document that at the expense of the patient moving on. Whereas a system that's been designed for ASCs from the ground up is going to get you there a lot faster. So
yeah, I couldn't have said it better myself.
Yeah.
What our fear is, and what we make sure of, right? Because an ASC is not an ASC is not an ASC. If you've seen one, you've seen one. They're all different, right? They're all very different. And I can't walk into either a single specialty eye center, GI center, or a facility that has a high population of very quick cases and tell them it's going to take 15 minutes to chart an 8-minute case. I can't do that.
No, you can't.
And that's what we try to service our market and make sure that we stay flexible to that end.
So finally, we have hit both sides of that market. Stay away from the small systems that are designed for practices and the big systems that are designed for hospitals.
John, I think you just came up with our new take on. We're the Goldilocks solution.
There you go. I love it. I love it. Thanks so much, Todd. It's always a pleasure.
Thank you, John. Appreciate it.
And last, but certainly not least, I had an opportunity to talk to our dear friends Jeff Flynn and John Van Valkenburg, the Vice President and President of the New York State Association of Ambulatory Surgery Centers. We talked about the conference itself, about the future of our conferences, and of course what's going on with the State Association. So let's listen. So this is John Goehle. I'm here at the 2022 Fall New York State Association Conference in Tarrytown, New York. I'm here with John Van Valkenburg and Jeff Flynn, and from the president and vice president of the association. We do this every year, sometimes twice a year, to talk about the event, what's going on. And I'd just like to start with Jeff. Talk a little bit about the conference and the planning that went into it, and this has been a fantastic conference.
Yeah.
Turnout's incredible.
This has been our most successful conference from turnout and also from vendor sponsorship.
Yeah.
Really engaging. I think the program itself, a lot of people got a lot of information out of it. Very excited with it. We're getting positive feedback from it. And I think as we move forward and we think about things for the future, we're obviously have an annual conference starting next year, but we're going to focus on doing regional things to really build the regions to grow the organization.
Yeah, and I think speaking as a vendor, and I know we have a lot of vendor listeners out there, probably especially with the special episode. This has been one of the best throughputs we have. That's a term that we use in vendor school, where we had people were forced to go past our booths. We had great engagement with the attendees, and I heard a lot of great comments from the attendees about their interaction with the vendors. So that's important. That's what kind of sets us aside, I think, with many state associations. Between Ann Geyer and myself, we probably attend half of the conferences, half the state association conferences. So that's a big thing to say that this is the place to be if you want to have vendor engagement.
No, we appreciate that. And it's also the opportunity. This is an educational process. The vendors are educating us on what's new and out there, especially as we're sitting 60 hours a week in our own silos. This really gives people the chance to get outside.
You're only working 60 hours a week?
Yeah, I'm banker hours. But this really that's a way for them to learn. But even the way we set it up this time, and it actually was a hotel's design, but literally you couldn't register and get your registration without going through the entire vendor
That was genius.
Which I thought was great.
It was genius, absolutely. What's on the horizon for the future with our conferences? We're making a major change in the way we're doing things.
Yeah, we're going to be doing a conference next year, only one annual conference, and that's going to be next year in Albany at the Desmond, and it's going to be next October 4th through 6th. But also we're going to concentrate going to regional conferences and doing some regional meetings in each area so that more localized information can come through. Certainly a big part you'll be involved in with doing some virtual things to really get people more involved, whereas they don't have to travel as far, be out of the office 3 days. We want to start getting people together that I can only dedicate half a day or a day, but we can do it in your area. So it's not a half a day or a day traveling too.
Right. That's one of the things that we've seen in all of the state conferences we've been going to lately is that they can't sacrifice both the administrator and the nurse manager. So we got to find a way to work around. Sometimes it's, one day for clinical, one day for administrative, whatever. We're thinking about all those things. There's no firm plans on any of it, but we're thinking about that. And for those of you that attended the conference, please fill out your evaluations. We take those things extremely seriously. We use them in determining, venues as well as the content and the structure of the meeting. So I just want to make sure we put that word out there also.
And in perfect example of that, for this particular conference, we changed the schedule a little bit because of feedback that we got from the attendees at previous conferences. And we're speaking right now. It's just after noon on Friday, and we just wrapped up the conference. It allows our attendees some time to travel back home rather than wrapping it up at the end of the day and people getting back home late at night. So again, that change was due to feedback we got from our attendees, and we listened and we changed the schedule, and I think it worked out really well.
And word about Desmond, Jeff and I and Lisa went to visit them a couple weeks ago. What an incredible venue that is going to be.
Yeah.
I mean, I've always enjoyed the Desmond, but they've really upgraded.
They really have done a major renovation, so it's really going to, and the way they've planned it out for us, as you know, this really will be able to grow even further at that venue.
Right. And an important thing about Albany is yes, it's further for the people from New York City to go to than Tarrytown, but it is one of the more central locations in the state, especially if it's accessed from the thruway, to be able to get there. So really anybody can get there from any part of the state. So I think
and we're hoping also state legislators, and we can get government people, but also the Department of Health, more people from there. We're very happy to have Dr. Morley here for this meeting to speak to us, but to get more participation from the Department of Health, they'll be able to do that from an Albany location.
Right. And we had quite a number of speakers that we interviewed through this. What do you think just talk a little bit about the general theme of the conference here and what you were trying to accomplish?
I think it was the overall theme was the future, because so many of us are in independent centers. Unlike maybe a number of other states, about 80% of us are independent centers. This gives an opportunity to look at what's out there for the future. When we talked about, just technology, as many of our centers are still on paper, and that's not the purpose. Looking at the option of national companies, if that's an option coming that people want to explore, but also the roadmap of an insurance company coming here and showing us how to work with them. And giving us the thing is, don't go to your contractor, go to the clinical interface in the company, was certainly a big secret to come out to seek out that person. But if we can do that with each of the major payers throughout the state, because obviously some are bigger in different areas of the state, I think we are giving our centers the roadmap to better success and just tell their great story of their great outcomes.
I appreciate that. John, I don't remember how many years you've been the president here. It seems
since
like
2018.
There we go.
4 years.
Yeah, it seems a lot longer than that.
Well, it's been a long 4 years. Well, the last 2.5 have been really long. For obvious reasons.
I think pandemic years count differently.
They do. They're like dog years.
That's right. So there's been a lot of changes in the last year. We're as an organization, we're getting better organized. We have greatly enhanced our resources. Talk about the changes that have occurred in the last. We last spoke in April, I believe. So talk about those changes.
Well, first of all, we've grown in membership. We now have over 100 facilities for the first time, as far as I know, and I'm assuming for the first time in history of the organization. No doubt, we have over 100 facility members and 6 associate members of the association. It's well over 50%, I guess probably about 60% of all the licensed facilities in the state. So we've grown as an organization. Obviously, our events have grown. This was the most highly attended conference that, again, to my knowledge, our organization has had, and I beg to guess that the organization has ever had. And the PAC, that's another big thing. And our organization has had a PAC in the past. But it was something that kind of went dormant. There wasn't a lot of activity going on with it. It wasn't being utilized. We got that going again. We worked with Capital Health Consulting. They brought some people in that knew how. I mean, I can tell you it's difficult because it's complicated. There's reporting requirements, and it is a little bit scary. And I know I was worried. There's a lot of legal issues regarding PACs and donations and everything like that. But we got the right people involved. We started a new one. We did it the right way. We're collecting donations now, and we're putting those funds to use to help build relationships with our elected legislators. So that's really another big, very recent development in the organization. And, we've also just recently had board elections. We've elected a new board. In just a few minutes here, we'll be having our first board meeting of the new board.
Got quick transition from a studio into a boardroom. We'll see how that works.
But that's another thing. So really exciting. We have a lot going on. We're going to talk about it at the board meeting, but there's new initiatives we're trying to put in place. And Jeff spoke to some of the efforts we're making regionally. Again, this, in my opinion, was not only our most well-attended conference. I think it was our best conference ever. The feedback's been wonderful, both from the sponsors and from the attendees. And, I think we really have some momentum. We've had conversations now with payers. We're having conversations with the Department of Health that weren't happening before. And again, we just want to continue to build on that momentum.
I'll tell you, John Morley from the Department of Health spoke. It is rare that you literally almost get a standing ovation for somebody from the department. He did an incredible job. Of course, he's a doctor who really has a good sense of humor and a good thing. His presentation was fantastic. It's too bad we couldn't interview him. I know the Department of Health has different rules about those things, but he would have been fantastic on this. Talk about the website, changes that we made to that. And
yeah, absolutely. Since last year, we rolled out a new website. It's meant to be more member engaging. Members are able to log in. There's some features in there with regards to communication and networking amongst our members. And there's other tools through it that really we're just kind of scratching the surface, I think, with what we're going to do and what we're going to be able to do with the website. The website itself is nysaasc.org. And
old dogs like me, I could actually figure out how to do it. So,
yeah. So
I got the young guys here, but the old guy, no, that's not so easy. So if I can do it, you can do it.
So listeners are welcome to obviously go and check that out. Certainly, if you're a member, you're going to want to check that out regularly.
Yeah. And we'll provide a link in our show notes to both the website as well as the registration page for that.
Wonderful.
So.
Just one other important initiative to mention is that we actually have gotten the New York State Assembly person to introduce a bill to put a member of independent ASC member on the FIPIC Council, and we now have a Senate sponsor too.
Wonderful.
So moving forward, that's key for our development further also.
Yeah, and for the listeners, the Public Health Council has never, ever in its entire existence ever had representation from the freestanding ambulatory surgery industry. And this is time.
First step.
It's amazing that it's gone this long.
Overdue,
that type
absolutely.
Well overdue. And again, I wanted to circle back to the regional because it'll be another year before we all get together to talk about this, and yet things are going to keep going. So it's important to, again, emphasize that these regional things will be kicking off very quickly. There's a bunch of us that are super excited about it and are just like, we're gonna push forward as quickly as we can. So keep an eye out for that. We don't really have any news about that yet, but watch the website. We'll mention the regional things in the podcast in our section 3 where we announce upcoming events. So keep an ear out for that. As always, I appreciate your time. We got one more thing to do before we close this conference out and have this board meeting. But thank you so much for taking the time to talk to our listeners.
Thank you, John, and thank you for
John.
your support of the organization. Helping with these events and also for the podcast.
I appreciate it. Thank you.
Thank you.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, Trivalence, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable insights. Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you are interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.